Professor has arrived, Dr. Kelly Starrett. How are you doing, sir?
Nice to see you. Good day.
Oh, hey.
Good day.
How's it going, everyone?
Oh,
Good.
fantastic.
All right. So basically, today I just wanted to open this up to kind of dig into Kelly's, I guess, venture through being a physical therapist. He's a coach, he's a writer, he's an advocate for like health and human performance, and kind of an inspiration for what a physical therapist can be for patients. Because I think a lot of the time we get pigeonholed into, well, they have a ACL tear and we miss the person in front of us. And I think Kelly has a few valuable clinical pearls that we can use in practice to kind of expand the potency of our interventions for patients. So I think clinically we can get some useful advice from him, but also just as an entrepreneur, because he's been able to grow businesses, write books, and speak very well through a DPT vantage point. So I think career advice for a new grad would be kind of how I want to approach this meeting.
Excellent. Well, welcome, everyone. I am coming from San Diego. There's this team, this rugby team called the All Blacks. They're in town playing Fiji, so I'm down working with the team this week. I just spent the morning at the Olympic Training Center and ran some bobsled athletes, and tomorrow we'll dash over to Naval Special Warfare, which is the West Coast SEAL teams. And the point of all that is there is no one better prepared to talk about sort of unlocking potential and thinking about performance and capacity than physical therapists. I think oftentimes we're playing a lot of defense when we're set up to play defense. We only see people after injury or surgery, and that can really kind of end up potentially inadvertently coloring some of our expectations and some of our perceptions of what is possible with the field. So, what's fun is being able to take this same hat that allows me to work with someone with bad knee OA or after an injury, or understanding tissue healing times, or sort of the psycho-emotional components of being able to meet someone and understand sort of where they are and how we're going to return them to their role in society, their role in their family. We can apply those same principles and just spin them upwards. So I tend to, for example, not use a whole lot of corrective exercises. It's just not what I do. And part of it is it doesn't fit into a schema for me where I'm interested in regressing and progressing sort of foundational type 1 first principles. So, we can do a lot of things that babysit tissues, for example, or help us manage someone who's acute. But ultimately, I got to get them on a scale to be able to continue to scale up. And for me, when I give someone an intervention that doesn't allow me to progress, make more complicated, sort of scale up, scale down, that's part of my own rationale for I might not choose this selection for a long term. A clamshell is a great example. Someone's very acute, can't do anything, but we don't see what a 1-rep max clamshell is, right? We don't see clamshells necessarily being of utility in very high performance situations. Maybe that clamshell now becomes the monster walk, and maybe that suddenly we're starting to look at foot position during squatting while we're using a mini band. And suddenly we're realizing, how can I quickly get this intervention to be appropriate for the person in front of me in an acute stage? And then how am I going to continue to progress that intervention or that thinking? How do I identify if someone has enough range of motion? Who owns this idea about position? How are we matching position in our language of high performance? And more importantly, who owns those things? So one of the things we see, for example, in a high level, in a lot of our high performance environments, our physios are busy managing really acute injuries and tissue trauma and surgery, and they can't be in the gym and they can't be on the field. They can't be on the pitch. And so sometimes there's a big disconnect between what this person's job is day to day and the person that you're seeing on the terminus of that injury, right? And that actually matches a little bit with sort of how we traditionally practice. And so one of the things we're always asking is, if the physio is busy doing her job of getting this athlete returned to play or return to sport or return to life, then, is range of motion important? And is access and movement choice important? Well, yes, I would argue it is. Can an athlete achieve the techniques that her coach is asking her to achieve? And oftentimes what we see is no one owns those positions. The strength coach doesn't, certainly the position coach doesn't. So we are spending a lot of our time thinking about where and when can we put these interventions in so that we can give this person agency and control over their bodies. And we might as well just take a step further and say it's not just about range of motion, tissue health. We can actually talk about resiliency, durability, tissue health, tissue tolerance, and performance if we're not also experts or at least competent in nutrition, competent in sleep, competent in looking at and assessing someone's lifestyle as it's a component to their ability to move and to have access to their movement system and sort of be able to really turn the dial up to 10. And at low loads and low speeds, probably doesn't matter. We can get away with a lot. But ultimately, what we're trying to do is say, hey, yeah, I know you can eat little snack cakes and smoke cigarettes and move at a low load at low volumes, and you can do that for a long time. Human beings are immensely resilient and robust. We're not fragile creatures. You can round your back and pick up your pillow. It's fine. But at high loads, high speeds, we want to understand what the best practice is so that we can make choices and teach towards the highest expression of a movement and the highest expression of human physiology. And I think we're really set up to be in this position where we can take a big bite at the apple and really begin to understand how these complex systems interact to give a person so that they can feel better and then have more movement choice.
I have a big kind of question that's kind of been haunting me in my decision to become a physical therapist. So it's when we learned about functional medicine. So this is the scope where you're looking at a patient through the lens of sleep, pharmacology, nutrition. These are all very powerful interventions. And I think the movement system is a powerful intervention to change the physiology of a patient. So if you have hypertension, aerobic exercise is medicine. But how can we leverage all of these at the same time in a functional perspective? Kind of like what you're saying, you should be competent in changing someone's nutrition. But if they have diabetes and they have hypertension and we're not addressing nutrition, I feel like that's malpractice. But for a physical therapist, it's not necessarily in our scope of practice to manage glucose, right? So how do you feel about the functional medicine approach of doing all of these other interventions that's not necessarily the movement system?
Let me go a step further. And really what we can start to say is who is going to spend this much time with a patient, right? So what we're looking at is who is, in this systems approach, who is talking to this person about their sleep and programming prescriptive isometrics and aerobic fitness and resistance training. Who's doing that? Well, I'll tell you, it's not physical therapists because the whole system of physical therapy isn't set up for that. So if I get a 45-minute eval, because you're lucky to get a 45-minute eval, and it takes me 4 weeks or 6 weeks to get that eval, you are not really relevant to the conversation. And if I only get 30 minutes with you every week or every other week, once again, to do what? Have a conversation about your, is that the kind of management we should be doing? And more importantly, is that the kind of system that's going to set up for the kind of care we're potentially able to provide? And the answer is no. And the answer is that we're at sort of this dissonance and crossroads between the potential care we can deliver someone and the care that's getting reimbursed by the gatekeepers of insurance, by the systems and the models that are set up for that. So it turns out physical therapists could be great participants, guides as coaches, health coaches who happen to be trained in physical therapy. But if you're going to have this conversation, give someone a stick figure and follow up in 30 minutes, and what's the connection between? So it turns out probably some kind of health intervention or a health coach that a physical therapist is managing would work on our current system, right? Where, hey, I'm going to set you up with this health coach. That health coach is checking with you daily on text. That health coach is following through. And then maybe that in our current situation, we're going to have to find this person a coach. You have to find this person. And as a doctoring profession, it may not be me who's delivering that, but it's me who's helping coordinate and manage that for this person. right? And so suddenly we're also asking, well, number one is, yes, I can do those things. And sometimes I need to be able to come in a performance director role. I'm running in a performance director role for a university team right now. And mainly because I have some ability to see, hey, we're not actually eating between this practice and the end of practice. And so, hey, what are the behavioral interventions, nutrition, what snacks, what nutrition are we going to give for these athletes to be able to, not fall into reds, not have, soft tissue strains because they're, et cetera, et cetera. So again, I think what we need to be thinking about is what kind of practice do you want to have? Then let's work backwards from there. So it may be that you taking an insurance model is never going to work for the kind of practice you want, right? And that's okay. That's not an area of physical therapy. It's the saying that, hey, this has gotten us here, and now we're ready to take another step. It may be that in the Army model, where there's one physical therapist who's helping to manage 10 different PT aides, we'll put them in quotation marks, right? But use that word instead of aid, PT aid, say coach. Like, why couldn't I manage 20 people in a day, write programs, adjust programs, touch base with someone? A lot of what we're doing as physical therapists is unskilled interventions. Unskilled that we could hand off, make a video for, teach someone to do themselves. Honestly, there's probably a handful of skilled interventions that would be really useful for us to be able to do. But let's go ahead and say, one of the, I think, pieces of original feedback or pushback we got after, becoming a supple leopard is that we moved a lot of skilled care, what had been thought of as skilled care, off the table and into the hands of the actual person. And we're seeing that now on the internet large, but there's a lot of things that you should never have paid or taken time off from work to get a physician's referral to go see a physical therapist for. Those things should be on the net and ubiquitous. What you're looking for is complex management. You're looking for complex interventions. You're looking for someone who's failed out, and you're using this integrated approach to find out what this person needs. And I'll give you an example. I'm working with a very, very high-level Olympian. He happens to be a surfer. His name's John Florence. And when we started, he is our Olympian. He's probably going to win the World Cup this year. And when we started a couple of years ago, one of the first things I asked is, before we get into like your hip mobility, right, or your strength training, tell me about your sleep. And when we got into his sleep, it turned out what we really were talking about was nutrition. And so me sort of layering in this first layer of, hey, here are these foundational principles that aren't very radical. Let's see if we can hit these things. And then let's get you someone who's an expert in preloading, in management, in fueling, in all of these things, who's going to look at this. Let's bring someone on the team. And so suddenly I'm in this role where, hey, I can deliver first principles, but now I'm in a team situation, and it doesn't matter. And then I can also look at, when are you strength training? What kinds of things are you doing as a skilled intervention level, or as an expert person? And I don't have to be the person delivering that info. I don't have to be the person delivering that care. I have to be the person coordinating that care. And that is what a physician would do, right?
Yeah, I think that's
because you're the best in the world at mobilizing hips doesn't mean you should be mobilizing all the hips.
I think what you said, like, I just did 2 outpatient rotations, and it was very, it was good. We had a lot of tags to use, and I think when you said a lot of what PTs do, especially in outpatient, is unskilled, because it's not a lot of complex physiology. It's just orthopedic, like strain set.
Yeah, teaching people how to move, teaching people to do the, the strength training, or the tendon loading, or soft tissue loading, or the soft tissue mobilization. Again, unskilled. And let's redefine what skilled care is, and really talking about the highest levels of the profession are. And I think anytime where we can move ourselves to a role where, hey, of course I can jump in there and teach squatting, and I can work on your Olympic lifting, and I can tweak your downward dog, and I speak Pilates, and hey, we can find out if you're just eating enough protein and carbohydrate and fiber. Those are things that are very easy to do. So let's go ahead and now turn the tables up and see if we can clear our schedules so that we're not the person. In some situation, we worked through a model where the best model was one physical therapist for one person for an hour. And I would say that that's super cool. But again, you may not need me for an entire hour. If you come and see me at my facility, I may be doing some manual therapy. We may be standing up and working on your technique. We may be spending 20 minutes looking at your environment. So there's nice to have a lot of time. And again, I think the physical therapist may be the only person who potentially has enough time to help an athlete work through this complexity of environment, training age, injury history, right? Current training load, competition. I think it's okay.
So your advice would be to take the Army approach in the sense that we have the foundational principle, like education for all of these things. And our goal is to give the patient or connect them with a valuable intervention. So whether that be sleep or nutrition, rather, if you can give it with your own like handout or education, or do you connect them to someone who has the value?
Well, let me jump in there and say that no, a handout is not going to get it done. How do we know? Well, we've been giving handouts out for 20 years or 30 years, and it hasn't changed anything. The handout goes, if someone handed you a handout with some stick figures, you'd be like, this is not important. You gave it to me on a handout, right? This is not important. So what I'm proposing is that we find a team member who may have more time. And ultimately, this is about being able to scale your time so that you can do the kinds of thing and spend the time on the intervention. Look, my PT school was attached to the World Center for PNF at Kaiser Vallejo. So we were very fortunate. We spent a lot of time at actual Kaiser Vallejo in their rehab facility. And sometimes you could not just do a 20-minute intervention with a person with a spinal cord injury or a head injury. And so ultimately, yes, I want to be able to scale myself, but I also want to be able to free up my schedule to work through complex interventions that really require doctoral level issues. Getting someone to follow up on, sleep tracking, that's not a good use of your time. So how can we take that PT aide, for example, and turn them into a health coach? And this is the person who's going to follow up with you. This is the person who's going to get you on the walking plan. This is the person who's working towards shaping specific behaviors for that person towards interventions that are going to change the physiology. But how many of you are asking your patients about how much walking they're doing and how that walking does or does not impact their sleep and how it does not, have you noticed how your tissues get? We have a lot of things to get through. If we're building actual problem lists, we are ignoring the real problem list, which is this person no longer is, in an environment that is conducive to movement. They don't get any sunlight. Look at how they're eating. What we're doing is we're giving interventions that may just be inappropriate or insufficient given sort of the volume and the gnarliness of what we're overcoming. So this is a chance to reimagine what's conceivable as a field and say, how we best deliver this care. I think that's really exciting.
Does anyone else have any other questions for Mr. Starrett?
I do. So coming from a sports specialty world, what would you say is your main pillars that facilitates recovery the best for those athletes, and how it may contrast to the traditional approach of physical therapy?
Well, let's say that first of all, physical therapy is not in the business of handing out interventions to reduce session costs for sport or activity. It doesn't mean we can't become the experts and the go-to there, but that has traditionally not been our training. And no one ever goes to their physical therapist and say, how can I recover from my marathon training? No one does that. So we're naive to pretend that someone's going to seek out get a physician's note or self-refer, talk to their physical therapist, unless their physical therapist is part of their performance team. And that's part of the role of the team. The All Blacks have a strength coach. They have cognitive, coaches. They've got nutritionists on board. They've got There's a whole group of people, and you can't tell what their role is because they're out on the field, right? They're all out they're all handing out snacks. They're all doing the recovery. So ultimately, we have to sort of look at, we can talk about first principles, but that's not even the place to start. What is this person capable of doing in their environment? And where am I going to put the best intervention to have the most significant outcome? So, one of the things that we tried to do with our last book, Built to Move, was to establish actual movement vital signs and actual behavioral vital signs around some of these key pieces. So, for example, human beings need a minimum of 7 hours of sleep for survival. 7. 8 hours is our actual minimum. And if you take people and put them in a dark room for 2 weeks, after 2 weeks, they will all have sleep adapted and they will all sleep 8 hours, period. Then you can put them in the dark for 16 hours, and initially they'll sleep for 14 hours, 15 hours, but then after they're sleep adapted, they'll all sleep 8 hours. The German word for night is the word letter N and the word 8. The Spanish word for night is the word 8 and the Spanish word letter N. And you can go on and on and on, and you'll be like, oh my gosh, it's almost like people know that we're supposed to sleep 8 hours. So now let's add some additional load. Let's add some additional stress. Let's grow a body. Let's try a complex skill, right? And what we see is that 8 hours becomes our true minimum to really understand inputs and outputs. So the first thing we could probably do is say, well, this is a level intervention where I need you to start tracking your sleep. So at the very minimum, we have everyone we work with get into bed for 8 hours. No phone for 8 hours. You don't have to wake up, but you can't get on your phone. You have to lay there and rest for 8 hours. We have to readapt people to sleep. And for athletes, it's closer to 9. For a growing body in an athlete, it can be closer to 10. So we can talk about decongestion and blood flow restriction and Normatec boots and rolling and right. We can talk about all those things, but if you're getting 7 hours of sleep, you're in bed for 7 hours. You go to bed at 11, you get up at 6. You're sleeping in the 60s. So now I can't even tell truly what the inputs and outputs are because the data is so dirty. So now we can start to ask, well, hey, let's look at your environment. Is you a person who could benefit from more steps? So one of our thresholds, look, if we could give all our patients a pill that would reduce all-cause mortality by 51%, we give them that, right? All-cause morbidity, all-cause mortality. Yes, give me that pill. I'll hand it out to all my patients. That's walking 8,000 steps a day. So suddenly we recognize that 8,000 steps is going to be crucial for decongestion, for loading, right? For just having strong feet, for some exposure. The research is that the average American is spending 120 minutes outside a week. So we're not getting any sunshine. We're not getting any early sun exposure, late sun exposure. We're not moving our bodies. And what we're doing is we're bringing in these complex physiologic systems and we're monkeying with them under these primary stressors, right? This is not, I'm talking about sleeping more and walking. Like there's like, show me the science. There is reams of science about it. And right, you can't come up with a single intervention that does not point to this. But what we see is, boy, it's real difficult for me to understand what's going on with my intervention around your pain and desensitization if I only see you every 2 weeks and you're not sleeping and you don't move, right? Now we can start layering these things. So first and foremost, what we're always asking is, what can this person do? And then at a high performance level, we're always putting this through the view of how can we reduce the session cost? So the old model of let's outwork the competition doesn't work anymore. Everyone is working freakishly hard. Do you think Fiji, again, I'm down here with the All Blacks, is Fiji outworking the All Blacks? The answer is no way, impossible. So now what we really talk about is what are the sets of behaviors, nutrition, feeling safe, feeling connected, sleep, walking, decongestion, soft tissue work. What are the aggregation of behaviors where we can reduce the training load cost on the body? And over time, the person who pays less cost for the same amount of training will perform more work, will show up for their family on the weekend, will feel better. So you can substitute, All Blacks for, hey, I'm working at a company and I'm on a deadline for work. I have a, final, I'm a high school student. I mean, the research around, physical therapists love to say, talk about injury prevention. We can't do anything about injuries. I'm like, bullshit. If I get this kid to sleep, I can reduce injury risk by 50% by getting them to sleep, right? So something that we realize is, boy, there's a lot we can do, but we're not set up or codified to do that. And then when someone comes in with knee pain, is a lecture on sleep and sleep intervention is going to be the first thing I reach for? It may not be. But I'm going to have to get there eventually. It's so cool. Literally, one of my friends, his name's Curtis Rayfield. He was a strength coach for the Warriors. And there was another strength coach for the Warriors who was a physical therapist. And they wanted to sort of condense the position to a single person. Which person got it? The really good strength coach or the really good strength coach physio? The really good strength coach physio. Of course. And I was like, Curtis, sorry, but you don't have a DPT. You can't manage. You can't understand. You don't speak the language back and forth. You couldn't take an athlete who's right out of surgery and hand it off to a physical therapist to be able to scale and appropriately manage that person. I'm going to choose a physical therapist. So he's like, what do I need to do? I was like, you need to go to physical therapy school, which he did. And now he is the sort of strength coach, performance director for the New York Liberty, the women's team. And, it's because the physio is in such a good role. So I think one of the issues for physios is that we have made this enormous investment into getting to school. Getting into school is insane, right? The number of hours, the observation, the volunteering, it's insane. Like jump through these 300 hoops, then go into a freakish amount of debt. It's we are gluttons for punishment. And oftentimes we think, okay, I've arrived, I've got my DPT, I'm good to go, right? Show me the money. Sign me up for that 100K job. And what I want you to think of is physical therapy school is a place to be from. It's the way that allows you to have your mark of professional socialization. We've trained you in order to do clinical, critical thinking, right? We can use the scientific method. We're smart enough to know and be able to start to understand research and not just be blind. Like, this paper says, and I only practice in this 30-minute thing, and I only have a carpeted, floor and a hung ceiling, and I don't have any weights, and I don't teach people to move, and I lay them on the table. Dude, that's the worst physical therapy there is. What we should be doing now is saying, I'm classically trained as a physical therapist, and now I'm going to go chase this thing down that I'm hyper interested in. And that is really powerful. And we have a lot of opportunity to take this classic education and then have it meet our needs.
Yeah, I think that was very well said, way how we can be more than just the DPT. The DPT is a starting place. Because
It really is a starting place.
I have a passion to help people, and I just reading the literature, there's so much more that we're not necessarily taught in school. I mean, we're exposed to a lot of things, but especially looking at jobs, because I'm going to graduate pretty soon. Looking at the insurance model and okay, do you want to work in a hospital system? There's all of these hoops to jump through. There's physician-owned practices that are peer-to-peer, looking over your shoulder. What actually are you doing with your patient? So I don't know. I kind of want the freedom to be able to give the value that I think is going to be best. And I don't know, what advice would you give to escape that system of reimbursement and insurance and productivity so that you can do the best for the person in front of you?
A lot of times we're making decisions about the kind of practice we end up in because they're economic decisions, or we're in a place where we feel we're economically held hostage, where I have to pay the student loan debt immediately and I need to start working immediately. Well, who works 50 hours a week or longer and then also is hunting for a job and also has a side hustle and was that's a lot of time. So suddenly you realize that, man, if you start with the idea of what is it I want to do, then super cool that you got, let me give you an example. Turn to career. There's an incredible program here in California called Junior Lifeguards. And they take young kids and they develop watermen and waterwomen who are very competent in the surf, have huge aerobic engines, learn life. And then when they're 16, 17, they kind of go down and become sort of official lifeguards. And then at 18 plus, they can be hired by the state and be able to feed themselves as sort of working lifeguards, working life-saving professionals. So pretty cool that this skill set terminates in an entry-level position where you can feed yourself. I want the DPT initially graduate to be viewed in that same way. Super cool. You now have a skill that will allow you to go out and feed yourself. You can support your family. You're not going to get rich. You're not going to have a job you love. But you now have a skill that is hireable in hospitals and clinics, right? That's great. But that does not mean you've earned the right or have the right to expect all these other things. We have now set you up where you can feed yourself with a profession. But that is not what we want. What I want you to do is say, what kind of practice do I want to have? What are the kinds of people I want to work with? What populations I want to work with? Then work backwards. And it may be that you're going to take this job, which is unfulfilling, high volume, insurance based. If we're not, that insurance system is corrupt and broken and not going away and left right away until we make it obsolete. But you have to be building a bridge, and it means you might be volunteering. It means you might be, working your side hustle. You do your day job for 32 hours a week, and then you do your side hustle. And I think when we start with that hypothesis, then we are no longer victims of, well, how come I didn't get chosen for the kickball team? Well, did you volunteer for the ninja kickball team, or were you just happy to make the kickball team? Right now, we're in a position where we're just typically happy to make the kickball team. The problem is you get in there for a few years and you're like, this is real bad, and I'm not growing. I'm not practicing the way I want to practice, but I have this house payment, I have insurance to be kept. And so you can really feel trapped in that model. And I think what we want to do is be creative. Look, I was at CSM and I talked to so many young students who are about to graduate, who all had side hustles, who are doing personal training, who had Instagram accounts, who are doing teaching. They were already starting businesses. Instead of waiting to graduate and start a business, they were already saying, hey, this is something I think I want to do. And what's nice about that is that allows us to enjoy PT school and to become hyper generalists. We can get all this wound care training. I'm never going to go to a wound care class ever again. But boy, that semester wound care was super cool. And I got to be exposed in kind of this classic generalist sense. So then as I was building, I already owned a gym when I was in PT school. I opened the 21st CrossFit in the world while I was a second-year student. And I got pulled into the dean's office and they were like, we think you're crazy. And I was like, you're crazy if you think I'm going to wait around and hope I get like some PT job. I'm going to go create my fantasy job today. And I think that's what I want us to do. Know that this DPT degree is legit. It will allow you to work as a professional and be taken seriously by professionals. And if that's good enough for you, cool. And if it's not good enough for you, let's make sure that we're keeping an eye on the kinds of places we want to go. If you want to work with runners, then in PT school, I'm asking you, why aren't you already working with runners? Why aren't you volunteering? Where are your running clubs? Have you already made contact with the best running groups in the world? Not, you may need to make it. So how can you start putting content? And what we're asking you to do is, it's a lot. But if you want to have the job that you want, then I'm asking you to work backwards from the solution into where we are today. And that's possible. It's possible because Kelly Starrett was able to do it. If I can do it, I guarantee you can do it.
So I have a question. So like you do as well, I coach some people on the side. I do some running coaching and all that. And I look into not just rehab treatment or exercises, but prehab, preventative measures for injury. So
I'm going to push back. And let me push back. I have no idea what prehab.
Oh, like preventative injury, like making sure the structure, like joints, are strong enough to make sure injury does not occur.
Can you do that?
I would say yes.
I'm going to push back and I would say no. But what you can do is the same sets of exercise to work towards performance. And yes, you can suddenly, right? Giving someone ankle range of motion, right? Restoring how their tissues are sliding on. That's not prehab, that's performance. Those are all. So there are two things, and I'm not trying to be smart here, but there are two things we can measure. One is range of motion, clear range of motion, right? Do you have access to native range of motion, normative range of motion, 1 or 0, yes or no? Why did I memorize North Carolina White? What is all that crap that I had to chew through? Because it turns out a normative hip in population of 90%, 99%, right, of the population is this much, right? We have a rotation window and flexion of 70 to 90 degrees, right? No one argues about how much flexion you should have. This is how much flexion to have. AAOS might say it's 135, and the American Academy of Podiatrists, whatever, might say it's 130. But we're talking about, that's a 5-degree range. Like, that's a tiny arc. So I can measure and restore normative range of motion, but I also can restore output. So making sure you have access to your range of motion, and then changes in your physiology are changes in expression of biomotor output, wattage, poundage, time, reps. Those things, when we focus on that, we'll always get injury prevention in the background. Because I have a brain that is not distracted by pain. I have a brain that has more movement choices to work with, right? And I have tissues that are more robust. If we always start with this medicalized model of rehab, I'm doing these exercises so I don't get injured. Again, can you show me that those exercises are changing your performance? If not, you're wasting your time. So I want to be very clear about that. We don't do any injury prevention. We work on restoring range of motion and improving people's outputs. I think that's a really important piece. So now, ask your question.
Well, that was just basically going on. What would you do to help people prevent injury in the future? But you kind of touched on that.
And what we see is, so we have a model in the Red State called D2R2. Someone shows up for pain. That's a check engine light, right? Pain is a request for change. We use pain as a signal, just like loss of force production. You come in and are running slow. You come in and are swimming slow. That is the same level of intensity and message importance as you saying my shoulder hurts when I swam today, right? Those are equal. I treat those at the same level. Why? Because pain is such a normative and normal experience of humans and certainly athletic kids. Walk into a room, I just had 100 girls at a water polo camp, 100 teenage superstars. Who's pain-free? One hand goes up. So I'm like, who's under the care of a physical therapist? No hand goes up. Isn't that weird? It's almost like physical therapy has nothing to do with the pain that these athletes have. So it can't just be about pain. But when we are chasing pain, because it's an easy place to begin with in conversation, again, not chasing pain, but the idea of, hey, let's be curious about that. We ask, can we desensitize that? Can we make the brain interpret that and see that as non-threat? Contract, relax, works great there. Isometrics work great there. Soft tissue mobilization looks great there. Hydration of the tissues could be great there. Suddenly I can ask around and say, well, what techniques do I have to desensitize those tissues? Because someone is super interested in their hip extension, but after their knee stops hurting. You know what I'm saying? Because that knee pain is hurting when I go downstairs and when I run, and that's the problem. Then we ask, can this benefit from decongestion? And oftentimes we have people not walking, they're running and sitting, they're riding, they're smashing themselves on a Peloton and sitting, and we're not flushing those lymphatics. But there's a reason we want that 8,000 steps, because I got to move that tissue waste along the lymphatic system. It's weird how the lymphatic system is all bootstrapped neatly into the muscle system, the movement system. So if we're going to just talk about garbage out and groceries in, oftentimes when we give people interventions, compression, walking interventions, right? It could be swimming, it could be Normatec boots, it could be NMES, right? It could be voodoo floss, right? What we could do is say, well, what are all the techniques I have to change congestion in this tissue? And oftentimes, again, that helps to desensitize the tissue. A less congested tissue oftentimes is less sensitized. Then we say, well, can this problem benefit from blood flow? Well, what are all the techniques I have to restore blood flow in an area? Blood flow restriction, actual movement and loading, right? You suddenly are like, oh, scraping, maybe cupping. So maybe that micro circulation from the KT tape, maybe that's improving circulation in this area, and that was enough for being less sensitized or less, right, interpreted by the brain. And the last one, this is crucial, is that we look at range of motion, and that we formally put range of motion. No one looks at range of motion. When someone comes in with knee pain, we do this complex regional interdependency thing for a reason. But you're not getting assessed to work on someone or paid for someone to work on someone's ankle range of motion if their knee hurts. You're certainly not getting upset, reimbursed for their lack of hip extension if it's the knee. This is why we need to make sure that we're very clear about helping people establish movement minimums for themselves and looking at can this intervention, desensitization, decongestion, reperfusion, and restoration of movement wrong. And so suddenly if I'm also interested in, hey, let's get you out of pain, but also all the things I just described can be utilized to improve power, improve wattage, right? Because I'm going to need to decongest these tissues after my major league pitchers throw 100 games, 100 balls. Their elbow is going to be congested and swollen. And so now we start to think differently about, hey, what are these interventions? Which tools do I have? And can we begin to layer these in to help people make sense of what's going on? And what suddenly you realize is, hopefully someday no one will need a physical therapist. But we'll never get there. This is job security.
I asked a question about going back to the educational standpoint and being in school, being involved, getting your feet dirty, just being in the field, connecting with teams and everything. What do you think about residency or clinical rotations and trying to specialize in sports?
Well, so one of the things that we talk about at the APTA, and I hope everyone comes to CSM this year. We have a huge 80-foot rogue rig in the middle. We're doing talks about performance, physical therapy. Well, it's going to be very exciting. We're going to do weight training. We'll have open gym sessions. We're going to have parties and prizes. We're just going to be it's going to be super fun. Sports physical therapy means that you are working with someone in a traditional sense who was doing a sport and got injured doing a sport. And they may not be athletes. They may just be a person that I'm a runner and I sprained my ankle, and that's now a sports PT. And what we found was there's a whole bunch of us working in performance therapy, which is how do we use the same sets of tools to progress someone's performance instead of just returning them to play, but actually putting them in a better state. So, to your question of, what does that look like? What I want to do is start to redefine what is possible, and we need a new category because it's not sports PT, right? It's not. It's performance physical therapy. And when we see people who need residencies, OCS, advanced training, those are typically to work in those populations. And I talk to the University of Southern California, their residency program. I've worked with Stanford residency program. And it's basically, think of it as DPT, advanced DPT training. So there are some people who feel like, hey, I'm going to work in a population where I need some advanced DPT training. That's great. Maybe it's advanced manual skills, it's advanced. So if my job requires me to have an OCS or advanced DPT training, then that might be great. One of our clinicians, Sean McBride, who was a member of our staff forever, came out of PT school at UCSF and just didn't feel ready to jump in and start swinging. So he did a residency at the Kaiser, and afterwards he was like, oh, I'm ready now. I have enough formal DPT training for my life to do what I need to do. And I don't think it made him a better coach, performance physical therapist, but it made him feel that he trusted his sets of skills and that he was good enough to be able to walk in and begin a real conversation. So advanced training is always great, but ask yourself, why am I getting that advanced training? Because it's not necessarily going to transfer immediately into dollars. But that's not why we should be doing it. We should be doing this because you lack a skill that's preventing you from living your dream. Let's go get that skill. And that might be a yoga certification. That might be a Pilates certification. That might be becoming a legitimate strength and conditioning coach with Exos, something like that, right? And so just keep in mind that I think those things are very valuable, but it may be that the reason we're doing them is for the wrong reason. That just, having DPT plus and OCS, no one gives a shit. Your family doesn't give a shit. They don't even know why you're still in grad school. You don't have a job yet. Like, why are you putting it up? So, but you're like, I need this job to go work in this situation, then go get it. That's a great reason for residency.
Thank you.
A lot of the schools now, we're finding things like orthopedics is optional. It's an elective. Neuro rehab is an elective. And that can leave you with real blind spots in your education. The Maitland Australian physio program maps, it's really heavy in this Maitland approach. We have a lot of physios who have, frankly, just piss poor hands-on skills, right? And I'm not into a conversation of like, hey, what's the best intervention for pain? And should we do payments? Dude, if something's not moving, I put my hands on it, get it moving so we can stand up and exercise. That's why I do that, right? I don't think, high grade, becoming an expert at, cervical manips, is the missing piece to your practice. But what you'll see is that a lot of people aren't getting that as part of their education. Great reason to go get some advanced training of some of these, manual skills so that you can, the same way I would say, hey, you suck at exercise prescription. One of the things that, if I have an Olympian coming in, can you assess their squat and tell me how to improve their squat pattern and why you're choosing that squat? And if you can't answer those questions, and this is a population you want to work with, let's go get those skills. And if you have money burn a hole in a pocket, and you want to stay in grad school because it's the best life ever, do it. What else?
Yeah, I have a question regarding like how you approach work because I mean, you have 24 hours in a day, right? And you said there's 8 hours minimum you have to sleep. I know some people say just sleep faster, so like 7 hours if you're like Jocko Willink or someone like that. But like how
Nope,
go ahead.
nope, that's not true. Can't do it.
You cannot sleep faster, it's a myth.
Nope, bullshit.
So yeah, that's what we'll say 16 hours. So like you have 8 hours aside from working and sleeping, like working for your boss. So like how do you approach the 8 hours like for your family and then working for yourself? Like how do you find a balance there?
Yeah, it's a great question. Ultimately, I was just talking to the strength and conditioning coach he's been there for 15 years, the head of strength and conditioning for Naval Special Warfare on the West Coast. I've known Josh forever. And one of the things he made a decision about was living close to his work site so that he could easily ride his bike there. Because that hour or that 45-minute commute was an hour and a half potentially or 2 hours a day where he couldn't be doing something like spending time with his family or picking his kids up from work or from school or training. And so the first and foremost is if you're asking people to invest in their health and wellness and you're not doing that because you're too busy for it or things that belong to you, then you're a lie. You have to have a physical practice as a physical therapist. And notice I didn't say exercise, it's a physical practice. That could be walking and kettlebell swings and Pilates. You could be a yoga meister plus, spin bike and you're going to kill it, but you better have a physical practice, and you should, be able to prioritize that. And what ends up happening is that when we start working hard, first thing out is our sleep, second thing out is our exercise, third thing out is our nutrition. And boy, if I take any animal or high performance person, put them in an environment where they're not sleeping and they're eating like crap and they don't exercise, guess what happens? I see degrade in their performance. So why would you not experience burnout? Why would you not experience unhappiness? How about all the relationships in your life? So why don't you get real about your own? If you're going to talk about fiber and micronutrients with your athletes and the people you're working with, you better show up with a huge bag of cherries and 3 apples today and just crush the fiber and the micronutrients. Otherwise, once again, what is good for the goose is also good for the gander. And we need to be models in this and work it out. And it doesn't have to be, we've trained everyone that exercise has to happen in hour-long increments. It does not. You can walk at your lunch. You could jump in and do a set of, power cleans or squats or kettlebell swings, or you work on your pull-ups and your break and then walk. There's so many ways to work this in. But if you're going to go hard, then you better have time to train and to sleep and to eat high quality food. And that means also getting your shit together so that you can be with your family and that you can be with your friends and be a human being. And you might have to lean into some of that on the weekend. But one of the reasons I don't train deload weeks is that deload weeks happen to the people I work with. Until I can put you in a laboratory and control all the variables, you're going to have a deadline or you blow it or some kid gets sick or someone in your family's sick. So what we're trying to do, especially with our PT profession, is to build resilience and tolerance into the system so that we can take on more stress. And if you're already working at the limits of your capacity because first principles are not being met, then as soon as you start to add a little more stress or want to go out, you're not going to have the available capacity. The short is you feel like you're working real hard, but I guarantee you, you're not. You're just at the limits of your ability to manage that session cost. And as soon as we really prioritize those things, what you'll realize is that you can show up and work harder for yourself. And that's what we want to do. Burnout's real.
So you're saying
But
you're saying the people that feel burnout are just not managing their
no, I didn't say that. I said one of the ways that we can minimize not burning out is making sure that we are doing the things that we know human beings need. Do I have meaningful, close relationships? Do I have sunlight? Do I engage in activity? Do I eat fruits and vegetables and protein? Do I sleep and walk? You've got to cover those things. And what I'll tell you is that it's more likely that you'll also see a correlation between feeling burned out and not having enough capacity and being smoked at the end on Friday versus, okay, now I've gotten through my day job while I work on my side hustle, or I want to show up for my kids, or I want to show up for my mom or my team. So keep in mind that we have to be thinking about these first principles. And if you're not, again, you're just lying to everyone else. who is in there with chronic back pain. They're giving them a BPS story, and you can't even manage your own biopsychosocial model. I don't trust you as a physical therapist if you're like, you don't have any friendships and you're not sleeping and, you're burnout, or you're lecturing me about that's the reason for my back pain. Come on, bro. So how do we do that? There's plenty of time. You've got 8 hours to mess around and do that stuff. Just may be that you may not have 2 hours in the day. What I'll say is that if I had a real physical therapy job, part of my practice would be getting together and training with my fellow physical therapists, right? As advanced training, as in service. So we would be getting together even if it's 3 days a week. That would be really amazing. But if you own the clinic, you can do whatever you want to do. And that's what I'm here to tell you. I want you to create the life that you want for yourself. And if it's going to be real hard, look, I think it's Buckminster Fuller, the sort of theorist, physicist. He's like, look, if you want to make change, you have to make the old system obsolete. You can't go into the system and then be like, yeah, the system sucks. You have to propose a new model that is so good that it makes the other model obsolete. And what I'm telling you is that if you just go in and suddenly you're working at a hospital and you're the lowest person on the totem pole and you're just trying to you're not going to change that system. You're naive. In fact, you're going to feel really frustrated and not heard, and you'll pout, but you're not going to change the system. But if you want to actually create a model, then there are other places. Frank Benedetto, Honey Badger. I would point at Danny Mattei of PT Biz. They're incredible, and their job is to help people build their practices, not because that practice is necessarily better, but it's better for you. And you having, again, that vision of what kind of practice and what kind of physical therapist you want to be, that's really the goal. I want you to do what you want to do with your field and your education the same way we would say, hey, what's important to you? Let's get you to be able to do that with your body. That's why we set these goals. Super easy. I'm 50 years old. I mean, you'll just snap your fingers, overnight success. I've been grinding and grinding and grinding and grinding so that I can get here. And I'll say it, there's no other job in the world that I would do. I think if I could freeze time, I would go get a PhD in, cognitive performance right now, cognitive behavioral performance. I think that is just this amazing opportunity, but I have no regrets about being a physical therapist. It's the reason I'm able to do the things I get to do and go to the places I get to go.
Why would you go into cognitive performance? Just kind of unlocking like dementia or Alzheimer's? Not even like put that.
Oh no, performance, mindset, performance. Yeah, the whole thing. Just seeing that, building that resilience, talking about all of those things.
So you're talking like because I guess you were working with like the All Blacks and like these 99 percentile humans. So just optimizing their cognitive ability to just like.
Well, a little bit of that, but also turns out the same principles of working at the highest levels of sports performance translate or transmutable to our families and our communities. In fact, that's why sport is so important, because it gives us a chance to test hypotheses and see what works under speed, load, real stress. We can stress test ideas. There's a lot of low-level physical therapy quackery that falls apart as soon as I bring it into professional soccer, as soon as I bring it into the Olympics, as soon as I bring in Olympic training centers, as soon as track and field. That stuff doesn't hold up. So again, we make valued statements about this is why we teach this way, because it allows us to scale up and it remains constant under high load, high speed, high stress, right? It doesn't mean that these other things are less valuable. They just don't continue to progress. They give us fewer movement choices, less capacity in the system. So it's why we might not choose that intervention or that way of thinking. So, ultimately, what I'm trying to do is always be in high performance sports and what can I learn here so that I can take it back to my high school kids who don't know how to, deal with anxiety or who are struggling to manage the yips right. So suddenly what you're realizing is sport is really the best place where we can take those lessons. And I just feel like some of the things we're learning from like Michael Gervais. If you don't follow Michael Gervais, you should absolutely follow Dr. Michael Gervais, probably the world's foremost, at least most famous performance psychologist right now. And his company is called Finding Mastery, and he's a great follow. And you'll be like, oh yeah, I got in the wrong field. I should have been a performance psychologist. It's just so sexy, and what he does, and the places he gets to go, and the changes he makes with the teams he's working with is profound.
All right, I think just to be respectful of Dr. Fred's time, we'll have one more question or one word of advice for the students.
I'll take one more question right here if it's available. So you've published several books. If you could retroactively put one thing back into one of your books that you know now, what would it be?
You know, I think it's not that there's something missing, but we've gotten better at explaining, right? And I think you know, going back and rewriting so someone doesn't get their feelings hurt, that's not useful. You know, so you can, you know, to align. I think, you know, what I always reserve the right to do is to continue to evolve and to progress. And again, progression is the key. So Supple Leopard has sold 1 million copies. It's been out there for over 11 years, but I inherited the language of movement fault, movement error. That's the physical therapist. That's a fault. A movement fault is like a mulligan technique idea, right? There was a joint fault. You clear the joint fault like that. That was the language I had. And now, like, I don't use the word bracing anymore, right? It just was non-specific, but that was the language I inherited. So, you know, we continue to evolve. We say things like, hey, can we get into a better organized position in this state? Bracing now has conjured up this idea that if you're a rigid, you know, automaton who's afraid to bend her spine, organizing says, hey, you're going to have to pick this litter up out of the helicopter to get the injured soldier out. How can we get you into the best position possible to maintain the most physiology available to you, right? That's a much more nuanced conversation. So again, I think we just continue to evolve. And then, you know, you can't, you know, if Supple Leopard was this thick, you know, that doesn't work. But, you know, the book we're currently working on, again, is Sports Performance for 12 to 18-year-olds, trying to make the household the performance director. How do we use sport as a scaffolding and a framework to create better societies, better families? And I think it really has the potential to do that. You know, we couldn't tell that story all the way. So I think the key is that you continue to evolve and you keep applying your models and seeing what part of the model isn't working. I spent a lot more time on behavioral interventions. My case report ultimately was on looking at barriers to adherence, what keeps people from doing what they say they need to do. And, exercise adherence in physical therapy is wretched. It's like a joke, like to do your exercises, it's a meme. And so how can we look at creating interventions in helping people with behavior modification that works for them and is consistent with them? And again, getting better at those things, I think, is really, really useful.
All right, excellent. Thank you for joining us for the TSPTA. Hopefully we'll get to see you in CSM Houston. So
heck yeah, I'll be there. Come find me.
Did not make it to Boston this year, though. It was a lot warmer in Texas, so I'm not too bad about that one.
That's right. That's right. It was really cold in Boston. So come to Houston. We're gonna do some really cool stuff, and we're gonna have a deadlift party at lunch. And we'll be doing every day. Will be a new weightlifting movement at lunch. We'll train together. We'll have open gym in the mornings. We'll have some tests who can do the most pull-ups and have prizes. You can get your section fees waived if you win our contest. So we're down to try to make it interesting. And then we're going to bring in a lot of speakers who are doing little 20-minute super talks. So you have a 30-minute chunk, 20-minute super talk, and then you have to leave the stage and go off to the side and talk to people for 10 minutes afterwards. And then that sets us up for our next 20-minute super talk. No CEUs, no one gets paid for it, but it allows us to really grab a whole bunch of people in there and do a bunch of talks. So we'll be running talks the whole time.
Yeah, it sounds very engaging, man. I'll see you there.
Fantastic. And there may be beer involved.